Hello, welcome everybody. So again, we'll just do a sound check. Can anybody tell me if the voice is clear? Am I audible? Anybody, please type in the message. Am I audible? Then we'll start. And tell your friends and classmates to join a SAP. We'll start in 1 or 2 minutes. Good afternoon, everybody. Okay, so Akshita says I'm audible. Muhammad Shakir says you're audible. Niranjan, Mairaj, sorry, Mairaj. So, okay, guys. So I think we'll start, and we're already late. One sec, guys.
Hi guys, check out the new car I bought from I made trading on excellent option. Let me show you how.
Okay, so we'll start, guys. Today, very few people have joined. I can see only 18 people have joined. Please tell everybody to join, because you will be marked attendance as per your presence in the live chat. And please be active and answer the questions whenever asked. Just only 24 people have joined so far. CR, please tell everybody to join. So we'll start. So today we'll discuss about the respiratory system, the anatomy of respiratory system, and physiology. I'm sure you have done both of these topics in your anatomy and physiology classes, but because now you're into clinical medicine, and a little brush up is good. And you should know that respiratory system is one of the most important systems in the body. We cannot say this is better than that system, and especially in this time, COVID infection is prevailing, and this virus is affecting mainly the respiratory system, and it can form embolus in the pulmonary artery and so on, and affect the respiratory system. And these patients who die because of COVID-19 infection, they basically die whenever there is a bad affection of the respiratory system. They start desaturating, and they cannot make oxygen, and they cannot diffuse out the carbon dioxide, and then they start desaturating, and that is the time the mortality rates, they go very high, very, very high. And that is why this system is very important. And if the respiratory system is not working optimally, it can affect your thinking, it can affect your brain, you can go into CO2 narcosis, and hypercarbia, hypoxemia, and it can affect your eyes, it can affect your heart, the workload of the heart increases, and you can develop a cor pulmonale, that is right heart failure because of a respiratory condition. And so see, like this, the respiratory system can affect so many things, and you can have acidosis, alkalosis. In response to acidosis or alkalosis, your respiratory system will respond appropriately to cause it or to alleviate that acidosis or alkalosis. And there are a lot of other functions, and we have to know the anatomy first. Okay, so it's not that respiratory system is just bronchus and the lungs. So when we say respiratory system, it starts from the tip of the nose, and tip of your nose till the lungs, and also the structures around the lung, the pleura, the visceral and the parietal pleura, the pleural space, the intercostal muscles, internal and external intercostal muscles, and the rib cage and the diaphragm. So you see, even the medulla oblongata. So everything forms is a part of your respiratory system. Even your abdominal muscles, the external nares, the platysma, the sternocleidomastoid. So these are muscles of accessory muscles of respiration. So they will start working when you are exerting more and your body needs more of oxygen. And like we say, the expiration part is a passive movement, but when you're running or when you're exercising, your expiration also becomes an active phenomena. So your internal intercostal muscles, they start contracting more forcefully, and they will help in the expiration also. Okay, and there are various drugs which can affect your respiration. They can cause uh, increase in tidal volume, like fort wind. One of the side effects or the effects of fort wind is it increases the tidal volume. Okay, and morphine, it liberates histamine. It can affect your respiratory system. It can cause bronchospasm. So like this, there are so many things which can affect the respiratory system, and certain poisoning, paracetamol poisoning, acetaminophen poisoning, and NSAID poisonings. So you can have respiratory manifestations in organophosphorus poisoning, so many poisonings, so many conditions. So anatomy of the respiratory system is very, very important. So the first organ is the nose and the nasal cavity, and we'll slowly, as we go into the slides, we will discuss in detail. Okay, from a tip of the nose, I will just come one or two slides ahead. So we'll come to this slide later on. And from the nose, there is a nasal cavity, and the details we'll discuss soon. Then the pharynx starts, nasopharynx, oropharynx, laryngopharynx. Then there's a demarcation there. The esophagus starts and the trachea starts. Okay. Then trachea divides into two bronchi. They divide into three primary bronchus on the right side, and on the left side two bronchus, bronchioles and respiratory bronchioles, alveoli, and so on. Then your lung tissue, and then there is pleural space. Then there are intercostal muscles and the rib cage, and below it is the diaphragm. So, and the medulla oblongata is controlling your respiration. So first we'll discuss about the nose and the nasal cavity. It is the main route of entry of air into your respiratory system. When you're gasping for air, you will definitely open your mouth also and breathe, especially when you're running. So you need more of oxygen. So your external nasal air, they are very not very efficient in taking in too much of air when you need it, and so then you will be mouth breathing also. And sometimes mouth breathing is a problem when you have adenoids, or when you suffer from sleep apnea. So these are clinical things. I'll try to touch the clinical side also, so that it becomes more meaningful. Just knowing the anatomy and not discussing the applied anatomy will be of limited use. So there is a left nasal cavity and the right nasal cavity, and it is divided or separated by septum. So there is a nasal septum, and when you will go to ENT, you will learn about deviated nasal septum or hypertrophic septum, and that can cause your patient to come to you with breathing difficulties. They will say they have a blocked nose. Sometimes these patients, the small kids, they will come to you with the broad nasal bridge, and they might be having adenoids, so they will mouth breathers because they can't breathe adequately through the nose. So this is the importance of septum, and cosmetic surgeries are being done to decrease the size of the septum and to give a shapely nose to people who want it. And so then there is anteriorly, there is a hyaline cartilage, okay, and the roof is formed by the ethmoid bone. Then the roof is formed by the ethmoid bone, and through this only, and the neurosurgeons, they approach the pituitary gland whenever there is a pituitary tumor. Then the floor is formed by the roof of the mouth. So nose is above the mouth. So the common roof of the mouth is the floor of the nasal cavity. So medially, I told you both in the center there is a septum, and the lateral walls are formed by the maxilla. So there is a maxillary sinus, frontal sinus, and whenever there is infection, there is sinusitis, and we do Walters view, we take the X-ray, and you will see there might be a air fluid level in the maxillary sinuses, and that will be maxillary sinusitis. So now you see this is the cross section. So the external nares, these are small vestibules. So these are the turbinates, superior turbinate, middle, and inferior turbinates. So they have a specific function, and then this is the opening of the eustachian tube. Okay, this connects with the middle ear. So your hearing can be affected if there is an inflammation out here. If you have pharyngitis, sinusitis, your voice will change and you will get blocked ear feeling. That is because the pressure difference does not alleviate, because this tube gets blocked. So this is the importance. So this is the floor of the nasal cavity, or this is the roof of the oral cavity. So posteriorly the pharynx starts. Okay, so these will be the tonsils. So tonsillitis is a very common condition which you will see, and it's commonly we call it sore throat. And sometimes there are a lot of small lymph nodes, they can enlarge and cause a lot of pain, and patient might come with severe pain, and it's called Ludwig angina, and you might confuse it with cardiac angina. Then from here the pharynx is starting out here. This is the uvula, this is the hard palate, this is the soft palate. So, and this is cilia turcica. From out here the neurosurgeon will approach the pituitary gland. So what is the function of the nose? So it can warm the air, and you must have seen whenever you drink very fast, you drink cold, you take cold drink or have cold milk or ice cold coffee, you just engulf it, you will start having some suffocation feeling in the chest and upper airways. So that is because of the cold sensation which triggers bronchospasm. Okay, so when the air is going through the nose, it's warming the air so that there's no bronchospasm. Then it will filter. It has small hairs in the anterior part, and they will block all the dust particles, and it will clean the air. And then because of the structure, because of the anatomy of the pathway, because it's not a straight thing like from here it is going to the lungs, it has to bend and angulate. So a lot of dust particles will be stuck here, and we will cough out, or through the nasal secretions they'll come out. So warming, filtering, cleaning, then humidification. Because if you take dry air, that is also not a good thing, because then when you will exhale, you will be exhaling lot of humidity from your internal system. Like through the respiratory system, you can lose around 1 liter of water. And that is why when you are exercising, when you are running or something, we are breathing fast, and at that time you will be losing lot of insensible losses water, and then you are advised to take more water, around 15 to 20 around 200 ml every 15 to 20 minutes after 10 kilometers of running, after every 1 hour. Okay, so that is to counter these sort of hidden water losses. Otherwise suddenly you will start losing sensorium, your sensorium will start going down, and you will not be connected with the surrounding. You might trip, you might fall. So that is important. So humidification. Okay, so after that, after the air is in the nose, nasal cavity, then it goes into the pharynx. So what is pharynx? So it is a part of the throat that is behind the mouth and the nasal cavity and above the esophagus and the larynx. So like before I said, so before the esophagus starts and the trachea starts, okay, that part after the nasal cavity, that is the pharynx. So it is lying posteriorly, okay. So its length is around 12 to 14 centimeter. It extends from the base of the skull and to the level of 6 cervical vertebrae. So superiorly there is base of the skull, inferiorly there is the esophagus, anteriorly there is an incomplete wall because of the nose, mouth and the larynx. These are open structures, and posteriorly there is areolar tissue and the first 6 vertebrae. So this is a very nice diagram, cross section. So nose and palate, uvula, nasal cavity. So then pharynx starts, nasopharynx, oropharynx. Oro is mouth, naso is nose. Pharynx behind the nose is nasopharynx. Pharynx behind the mouth is oropharynx, and pharynx behind the larynx is a laryngopharynx. This is the larynx. Okay, out here there is a Adam's apple, which determines how harsh your manly your voice will become in males, and it does not affect in the females. Okay, so as we discussed, so the pharynx has 3 main parts: nasopharynx, oropharynx, laryngopharynx, and below inferiorly it is continuous with the esophagus, and the trachea starts after the laryngopharynx. So this is another diagram, nice diagram. So the blue part is representing the pharynx. Okay, so this is nasopharynx, then uvula starting, oropharynx and laryngopharynx. So this is the esophagus, and then you can see this incomplete tracheal rings. So posteriorly these C-shaped rings, they are absent posteriorly, so they are called incomplete rings, tracheal rings. They maintain the anatomy of the trachea so that the trachea doesn't collapse under the pressure. So the pharynx is composed of 3 layers: mucous membrane layer, fibrous tissue layer and smooth muscles. And the blood supply is through the facial artery, facial vein and the internal jugular vein. So if there is a problem in any of these veins, so the pharynx can get affected. And likewise the nerve supply is through vagus nerve and the glossopharyngeal nerve. Okay, so what are the functions? So functions, it will help in hearing, protection, speech, and definitely passage of air and passage of food. And then your body decides that your epiglottis has to close when you're swallowing food so that you don't aspirate, and then warm and humidified air goes into your larynx, food goes into your esophagus, and you can taste because there are olfactory nerve endings, and in the hearing it will affect excuse me. And then there is, for protection, there are lymph nodes, tonsils are there. Okay, and it is also a resonating structure for speech, and it is very important for singers. So now we'll drop the esophagus, we'll go inside the respiratory system. So now we'll come to larynx. So the larynx is also called the voice box. It extends from the root of the tongue. It lies in front of the laryngopharynx, obviously because the pharynx is lying posteriorly, so larynx has to lie ahead, anterior to the pharynx. So it lies in front of the pharynx at the level of 3rd, 4th, 5th and 6th cervical vertebrae. So till puberty there is no differentiation in the size of the larynx between both the sexes, males and females. But after that your male hormones set in males, and the gonads start working actively, and then your larynx hypertrophies in males and your voice becomes heavy. So superiorly there is a hyoid bone and the roof of the tongue. Inferiorly it is continuous with the trachea. So it's a continuous windpipe. Anteriorly there are muscles of the neck. Posteriorly there is laryngopharynx, and third to sixth cervical vertebrae. So I hope till here we are very clear. This is another diagram. Just spend 1 or 2 minutes on this. So you can see this is the larynx, this is the epiglottis. It will close when food has to be swallowed. This is the trachea. These are the tracheal rings. So the larynx is composed of several irregular shaped cartilages attached to each other by ligaments and membranes. There is one thyroid cartilage, one cricoid cartilage, and two arytenoid cartilages, one epiglottis. So thyroid, cricoid, and arytenoid, they are hyaline cartilages, and epiglottis is elastic fibrocartilage. So the thyroid cartilage is the most prominent, and it consists of two flat pieces of hyaline cartilages, and they are fused anteriorly forming the Adam's apple. So these two arytenoids, they are lying behind the thyroid cartilage. So actually anteriorly you cannot see them. I will show you the diagram. It will become very clear. Then there is a cricoid cartilage. It lies below the thyroid cartilage, and it is hyaline in structure. You must have done this in your anatomy. So arytenoid cartilages are two pyramid-shaped hyaline cartilages. They are situated on top of the broad part of the cricoid cartilage. This is the epiglottis. Now we come to the epiglottis. This is a leaf-shaped fibroelastic cartilage attached to the inner surface of the anterior wall of the thyroid cartilage. The blood supply is through the superior and inferior laryngeal arteries, thyroid veins, and the nerve supply is through superior laryngeal nerve. Now see, color wise very nicely the author has defined. Green, this is epiglottis. Posteriorly you can see, anteriorly you can't see epiglottis because it is inside. Okay, so this is the thyroid cartilage. This maroon one, thyroid cartilage. It is a major main cartilage. Then blue one is a arytenoid. So I said they are behind the thyroid cartilage. Anteriorly they are situated. Okay, like this is the cross section, transverse section, and if you close it, so you can see the trachea. So the deficient tracheal ring cartilages are absent. Then this is the cricoid cartilage. So anteriorly you must have seen during an anatomy the sections. This is a cricoid, but inside it is a big one, this yellow one. So then there are conicoid cartilages. They are very small, two small structures at the root of the epiglottis. Now the functions. So more or less it is the same function: production of sound, speech, protection of the lower respiratory tract during swallowing, and passage of air, humidification, filtering, warming. Okay, so after this we come to trachea. So the position of trachea, you know, so below the larynx it is situated after C5. So trachea, it is a windpipe. It is a continuation of the larynx and downward extension up to the level of T5, T4, T5, where it divides into right and left primary bronchi. So there is a primary bronchus, secondary bronchus, tertiary bronchus, or a respiratory bronchus, and then the alveoli start. Length is around 10 to 11 centimeters. Superiorly, it is continuous with the larynx. Inferiorly, it divides into right and left main bronchi. Anteriorly, upper part, there is a thyroid gland. Okay, so you must have palpated. You must have been taught how to palpate the thyroid gland. You are asked to tell the patient to swallow and insinuate your finger the suprasternal notch and feel. So the trachea is also there, because when we do tracheostomy, that is the point where we do the tracheostomy. So this is applied anatomy. Okay, and you have to make sure you don't injure the recurrent laryngeal nerve. Otherwise, the patient will develop paralysis of the vocal cords and hoarseness might set in. So anteriorly, there is a thyroid gland in the upper part. In the lower part, there is arch of aorta and the sternum. Posteriorly, there is esophagus, and laterally the lungs. You see this structure. So this is the thyroid cartilage, cricoid cartilage, thyroid gland. Okay, then from here the trachea is starting. These are the tracheal rings. They prevent the trachea from collapsing, and this is where we do the tracheostomy. Then this is the arch of aorta. This is a brachiocephalic trunk. So on the right side only there is a brachiocephalic trunk, not on the left side. Then this divides into common carotid artery and the subclavian artery on the right side. On the left side, this is the common carotid artery. It divides into external and internal carotid artery. And this is the subclavian artery. It goes into the left arm. So out here, this is the carina. Carina is the point where trachea divides into two main bronchi, primary bronchus. Right primary bronchus, left primary bronchus. The plural would be bronchi. So this is the secondary bronchus. Okay, on the right side there are three lobes. Lung has three lobes on the right side. On the left side only two are there, superior and inferior. So upper, middle and lower on the right side. So there will be three secondary bronchus on the right side. On the left side only two secondary bronchus. So this is the main differentiating point, and in your exams also you can be asked to draw the surface marking of the various lobes of the lungs on the right side, on the left side. The left lung has a cardiac notch. Okay, so it's a curved notch where the heart fits. This is absent on the right side. So this is the main difference between the right and the left lung. So there is an oblique fissure which is present on both sides, which differentiates between the superior and the inferior lobe on the left side. And then on the right side there is a horizontal fissure which divides the superior and the middle lobe. Then there is an oblique fissure which divides between middle and the inferior lobe on the right side. So on the right side there are two fissures, on the left side only one oblique fissure. On the right side there is an oblique fissure and a horizontal fissure. And the clinical applied anatomy would be, sometimes you will see pleural effusion, a white line you will see on the right side in the horizontal fissure. There will be fluid in the horizontal fissure. So that is the clinical importance, and many times in the radiology spotting you will be asked that. So keep in mind that thing. And the right bronchus is small. Okay, right primary bronchus is small in length. The left bronchus is slightly long. You can see this is a very nice diagram. And the right bronchus is more straight. The left is little angulated. So if a child swallows a coin and you are in casualty, okay, and right bronchus is little wider also. You can see this is narrow, this is wide. So if you are in casualty, you are an intern on duty, and a child comes choking, the parents bring the child. He has swallowed a coin or a dice. and you are the only one there. You have to decide to do a bronchoscopy, and there is no one senior, and you have to do the bronchoscopy because otherwise the patient will die. So if you don't have any choice, if there is no actually no other modality to find where the coin is, you should go into the right bronchus first, because it is straight, wider, more chances that the child must have aspirated into the right bronchus. Okay, so this is a very important clinical aspect you should always keep in mind. Of course, it can go into the left bronchus also, but there is more chance that it will go into the right bronchus. And this is again a structure of this is the esophagus. So it's like, you can almost feel it is like a cycle tube. It's rubbery, elastic, the esophagus. When the food goes, there will be peristalsis. The food will go into the esophagus down. And this is a trachea, and it is patent. This distance diameter is maintained by these tracheal rings. Posteriorly, these cartilages are absent. See this absent out here. And these are C-shaped cartilaginous rings. Now, sometimes your patient will come to you and he will say, ki, sir, when I eat food, when I swallow water, the water falls into my stomach. Okay, so you might be feeling tempted. You might feel tempted to think that this patient has some psychiatric disorder and he's just cooking up conditions. But in scleroderma, there is fibrosis of the subcutaneous tissue, and the esophagus becomes like a lead pipe. So there is no peristalsis, and the subcutaneous skin of the skin over the face becomes very tight. Okay, so similarly in the esophagus it will be like that. The peristalsis won't happen. So if the patient swallows something, it falls into the stomach. So whatever he is saying is right. And in such patients, if you look for pallor, I have 2 or 3 patients which I must have shown to a few of you. And if you look for pallor and you just gently stretch the skin to lower the eyelid and look for pallor, so you get a feeling as if the whole thing is like tight and it is like plastic. So that is because of the fibrosis. So in the trachea, it is composed of 3 layers of tissue: fibrous and elastic tissue. Then there is smooth muscle. Then inside there is ciliated columnar epithelium. So what is the importance of ciliated columnar epithelium? The movement of the cilia is upwards towards the oral cavity. So sometimes you might inhale something bad or dust particles, and so your trachea, the ciliated columnar epithelium, in a brush type of activity in a synchronized way, it will help you cough out the harmful secretions in the trachea. So that is why in smokers you must have seen they cough a lot. They develop COPD, they develop secretions. So the ciliated columnar epithelium will help to cough out the bad smoke. So the cartilages, I told you, C-shaped cartilages, they are around 16 to 20 of incomplete cartilaginous rings. The blood supply is via the inferior thyroid artery and the bronchial artery. The venous drainage is through inferior thyroid veins. Nerve supplies through the laryngeal nerve. So this was about the trachea. Functions more or less same only. Support and patency. Mucociliary, it is escalator. Cough reflex. Warming, humidification, filtering. Okay, so till now, external nares, nasal cavity, pharynx, nasopharynx, oropharynx, laryngopharynx. Pharynx is continuous with the esophagus. Anteriorly, there is a larynx. Okay, there are various cartilages. Then the trachea starts. Trachea in the neck. In superiorly, there is a thyroid gland anteriorly to it, and inferiorly, anterior to the trachea, there is sternum and root of aorta. Okay, so till now, okay, and also trachea further bifurcates into Right and left bronchus. Primary bronchus, right bronchus is wide, more straight, shorter, it is 2.5 centimeter. Left bronchus is 5 centimeter in length. And the clinical importance I have told, if there is aspiration, you have very little time, the child is dying, and you are the only one, go for the right bronchus, go into the right bronchus. So this is a very nice diagram. So these are cartilages. So carina, here the division occurs. Primary bronchus, secondary bronchus, bronchus intermediate, secondary bronchus, secondary bronchus. So because there are 3 lobes on the right side, okay, so there have to be 3 secondary bronchus. Then the horizontal fissure will be here between the superior and the middle lobe, and the oblique fissure will be out here, more prominent posteriorly. On the right side, secondary bronchus, okay. These are the tertiary bronchus, tertiary bronchioles. So this is the division. So the structure is same anatomically and histologically. They are lined by ciliated columnar epithelium because they have to cough out the secretions. And the division of bronchi, bronchioles, further dividing into terminal bronchioles, then respiratory bronchioles, alveolar ducts, alveoli. Okay. So we'll just revise this again. Trachea, carina, primary bronchus, secondary bronchus, tertiary bronchus. Okay. So superior lobe, middle lobe, inferior lobe. On the left side, superior lobe, inferior lobe. This is again, it is a nice picture showing what happens in pneumonia. And out here it is a clear picture of a clear healthy person. There are no secretions, there are no air fluid levels. Out here there is a fluid level. This is fluid in the alveoli. Okay, so it come out here, then the ciliated columnar epithelium will cough out, help you cough out the secretions. So the ciliated columnar mucous membrane, it changes gradually to non-ciliated cuboidal cell shaped in the distal bronchioles. This is something important you have to know. The wider passages are called conducting airways. They will bring air into the lungs, and the walls are too thick to permit gaseous exchanges. So till the alveoli level is reached, the gaseous exchange usually does not occur. So the blood supplies through the bronchial artery, they drain out into the bronchial veins, nerve supplies through the vagus nerve, and lymphatic drainage is through the thoracic duct. Function more or less same: control of air entry, warming, humidification, support and patency, removal of particulate matter, and inducing cough reflex. Now we come to bronchioles and alveoli. Each lobule is supplied with air by a terminal bronchiole, which further subdivides into respiratory bronchioles, alveolar ducts, and then there are a large number of alveolar sacs. There are about 150 million alveoli in the adult lung. So this is how the blood supply is. So the deoxygenated blood from the pulmonary artery reaches the lungs. Then the gaseous exchanges occur in the alveoli. Then oxygenated blood goes back through the artery. Nerve supplies through the vagus nerve. Then now we come to the functions. So slowly from anatomy, we are moving to the functions, the physiology. So there are basically two functions. External respiration is there and internal respiration. External respiration is the gases exchange occurring inside the lung between the environment and the lung tissue. Internal respiration is like the oxygenated blood is oxyhemoglobin goes to the tissues, and at a cellular level the cells are washing out the carbon dioxide into the extracellular space, and the oxygen is diffusing into the cells. That is internal. So that happens in lungs, external respiration. So lungs there are two lungs I told you, left lung and the right lung. Left lung has two lobes and there's a cardiac silhouette there. And on the right lung has three lobes. Left lung has oblique fissure dividing superior and inferior lobe. The right lung has horizontal fissure dividing, separating superior from middle lobe, and there's oblique fissure separating middle from inferior. The weight is around 600 to 700 grams, is cone shaped structure, and length is around 20 to 24 centimeter, and it is color is usually pinkish if you are not unhealthy. And there are three lobes on the right side, on the two lobes on the left side. I have repeated enough number of times, I'm sure you will not forget it. And there are fissures, and in the center there is a mediastinum. Now before I forget, mediastinum has an importance. So sometimes you will come to pleural effusion and all these conditions after some time. Sometimes you will see a massive pleural effusion, but the mediastinum is in the center. It is not pushed towards the opposite side. So when such a thing you see on the X-ray, you should always consider some fibrosis of the mediastinal structures, some lymph nodes being there, and which will usually occur in tuberculosis or a chronic fibrosing condition. So in malignancies, usually you will see this massive pleural effusion without mediastinal shift on the X-ray. So lung has apex above, so slightly above the clavicle. In the neck, you will see the apex, and it is also called chronix isthmus, and you should always percuss it. And in the exams, from exam point of view, it is very important. You will be asked some question on chronix isthmus. Then there is a base formed by above the diaphragm. Then there is a costal surface and the medial surface. So this is a nice diagram. It's a beautiful diagram. So this is the chronix isthmus. Yes, Bhavan. The point of bifurcation of trachea is called carina. Okay. So this is the structure of the lung. I'll answer all the question afterwards because it's difficult for me to concentrate on the laptop screen and the mobile screen and talk and reply at the same time to the live chat. But anyway, it is good that you are participating. So you ask all the things you have doubts about, and I'll definitely offline mode I'll answer these questions. So you know these structures we have discussed nicely: right lung, left lung, superior and inferior, and on the right side three lobes. Now this is a normal non-smoker's lung. It is pinkish in color, the heart in the center, nice healthy. This is a dark, dirty, carbon choked, smoked, cigarette smoked smoker's lung, so which is bad. And once you have smoked around for 10 to 15 years, it will require you to stop smoking for around 10 years. After that, you can say your lungs are healthy again. So in the first place, never start such a bad habit. So outside the lung there is pleura. Okay, this is a very important structure, and I have written elephants because I might forget, so I just wrote it here. So elephant is the only mammal which doesn't have pleural space. I read it somewhere, so I found it very interesting. Rest every mammal has pleural space. Elephants don't have pleura. So I thought you should know this. And the pleura, it is a small sac-shaped serous membrane. There is a visceral pleura and the parietal pleura. So there are two layers. So they are very close to each other. They approximate each other. There is very, very thin layer of pleural fluid. In a healthy person, there will be very, very little pleural fluid, which is not demonstrable on clinical examination. So only after your pleura has around more than 250 ml of pleural fluid, then you might be able to percuss little bit of dullness, and that is if you do it very nicely. Otherwise, more than 500 ml, it becomes percussible. So the visceral pleura is adherent to the lung. Viscera, lung is a viscera, remember like that. Okay, so the visceral pleura, it is stuck to the lung. It covers all the lobes and the fissures. So you can just say that it is like part of your lung, external layer of your lung. Then there is a parietal pleura. So I have always kept mnemonics in my mind. So how do I remember what is parietal pleura, what is visceral pleura? Viscera, organ. So it is stuck to that, visceral pleura. Parietal. So whenever a child has some danger, so what do the parents do if supposing the child is going to come under a car or something? Your mother or your father, they will just run without thinking of their life, and they will engulf you in their arms, isn't it? So that is parietal pleura. Okay, so that is around the visceral pleura also. So the parietal pleura is stuck to the chest wall, the thoracic surface of the diaphragm, the chest wall. So how do I make you understand the negative pressure concept? So you remember, imagine you are wearing a glove on your hand, okay, and you imagine your hand is the lung and your glove is the visceral pleura, okay, and imagine if you are pulling the glove, there is a pressure, negative pressures building up between the glove and your hand, which you are now imagining it as lung. So if you are pulling the visceral pleura, so what will happen? Your hand will be pulled towards the direction of the pull. Same thing happens with the lung. So the parietal pleura, so whenever the rib cage is expanding, there is a negative pressure being created between the parietal and the visceral pleura. So that will create a negative suction. It will pull the parietal pleura, visceral pleura outwardly. And remember, the first rib is non-mobile. It is fixed. Okay. So God has made our rib cage in such a way that whenever you inhale, okay, the diaphragm will go down and your rib cage will go up towards the first rib. And the anatomical orientation of the ribs is such that when these intercostal muscles will contract, the chest wall expands. So the pressure inside the pleural space increases and there's a negative suction created. So that will cause a lot of air to move in. So we have covered all this. So this is the interpleural space. Okay. So these are the lungs. So the pleura are around the lungs. So this we have discussed, we just bypass them. So right lung, left lung we have discussed. Okay, the blood supply of the lung is through the bronchial arteries, pulmonary artery, where there is exchange of oxygen and carbon dioxide between blood and the tissues. And the venous drainage is through the bronchial veins. So per se, the lung, what energy the lung needs to work to cause diffusion of carbon dioxide and oxygen in the alveoli, that is by the bronchial arteries and the bronchial veins. The diffusion process is occurring through the pulmonary artery and vein. Okay, so this has to be very clear. And the nerve supply is through the vagus nerve. Function again same: control of air entry, warming, humidification, support and patency, removal of particulate matter, cough reflex. Now we come to what do you mean by respiration? This also we have actually discussed. So respiration is exchange of gases between your body cells and the environment. So breathing or pulmonary ventilation. So this is the movement of air from outside into the inside and from inside to the outside. So in the lungs, the external respiration is occurring, like I told you before. So in the alveoli, there is a capillary meshwork. Okay, so it's a single cell layer thickness where the diffusion occurs. So from the capillaries, from the veins, carbon dioxide is coming out, oxygen is going into the artery, pulmonary artery. Okay, so it's a very thin layer, a one cell thickness layer. So that is why you can imagine your lungs are so fragile, and the COVID and other infections, they will destroy that part through the antigen antibody deposition and autoimmunity, and your immune system just destroys your alveoli. So the main muscles used in a normal respiratory process are your intercostal muscles and the diaphragm. So when the diaphragm is pulled down, so that will help in inspiration. So superior inferior diameter increases, your intercostal muscles, your ribs will move up towards the first rib, and they will pivot around the point where they will expand outwards. So that will increase the pressure. And the expiration is a passive process usually. And when you're exercising, then the internal intercostal muscles might contract and help in forceful expiration of air, so that again you can breathe faster. There are around 11 pairs of intercostal muscles that occupy the space between the 12 pairs of ribs. Okay, so I hope you can imagine there are 12 ribs, 12th is the incomplete rib, and there are 11 pairs of intercostal muscles. So there is external intercostal muscle layer and internal intercostal muscle layer. The first rib is fixed. So this is the sternum. First rib is fixed. So you see, if your external intercostal muscle is contracting, it will lift up the ribs. You can just stand in front of a mirror and breathe and see. So it will expand outside on deep inspiration, and your diaphragm will go down. So we come to the diaphragm. So does coronavirus affect the pleura? Sumit. So Sumit, coronavirus, see, viral infection is something, virus can affect any part of the body. I have treated thousands of COVID patients, and by God's grace, I have been fine till now, and I hope to remain protected by God's grace. So COVID virus is just like any other flu virus, and any other virus also. It can affect any part of your body. Patient can present with diarrhea, fever, body pains, some CNS complaints, and some myocarditis, irregular heartbeat, hypotension, tachycardia. So you see, they can present with anything. Dengue again, they can present with, it causes serositis, inflammation of the cells. So these patients can present with colitis, ileitis, cholecystitis, hepatitis, renal shutdown, myocarditis, papillitis, pleuritis, pleural effusion. Yes, it can present with pleural effusion. And there can be patches, shadows inside the lungs, pneumonia they can present with, and increased secretions they can have, and desaturation will happen. And your brain can be affected. They can present with meningitis, encephalitis, ataxia, cerebritis, cerebellitis, ophthalmitis. So you keep on adding itis, and your patients with viral diseases, they can present like that. In fact, I always tell my uh, juniors that whenever a patient with gastroenteritis comes, and there's a history of diarrhea also, you must treat these patients very cautiously and very actively, because usually gastroenteritis patients, they will not have diarrhea, and whenever there is diarrhea, it is something more than just a diarrhea. Whenever there is fever with diarrhea, it is something more than diarrhea. So usually the virus, there could be a disseminated infection, but the patient has just started to present with gastroenteritis. Later they might develop myocarditis or respiratory failure, and so you have to be very aggressive. Likewise, algid malaria, so they can present with just gastroenteritis type of symptoms, and within minutes and hours they will go into shock, and you will not come to know what has happened to your patient. So whenever there is fever and gastroenteritis type of symptoms, you have to be very, very cautious. Monitor the pulse, BP, respiration, IV fluids, the urine output, the saturation, and you have to stay one step ahead of the patient's complications, and that will pay you in the long run. So yes, the virus can affect any part of the body, and it can cause any type of complaint. Okay, now we come back to the diaphragms. So the diaphragm is a dome-shaped muscular structure separating the thoracic and the abdominal cavities, and it forms the floor of the thoracic cavity and the roof of the abdominal cavity. So it's very obvious there is a thoracic cavity superior to the abdominal cavity, and diaphragm is in the middle. So there is a central tendon from which the muscle fibers will radiate out to be attached to the lower ribs, to the sternum, to the vertebrae, in the form of two crurae. And when the muscles of the diaphragm, they are relaxed, the central tendon is pulled downwards to the level of T9, enlarging the thoracic cavity in length. So you, whenever now you are into medicine, you have to know the side effects of the medicines also. For example, xanthines, methyl xanthines, deriphyllin, we use left and right. So it is not just a bronchodilator, it will cause tachycardia, it will cause diuresis. It is said to have to increase the force of contraction of the diaphragms, which improves the ventilation of the patient, and it will stimulate the brain little bit, and the patient will feel better and breathe more confidently. So there are so many things, so you have to keep in mind this side note. So this decrease in pressure in the thoracic cavity and increases in the abdominal pelvic cavity. So this will cause the diaphragm to move down and the pressure will increase. So this is the left dome of diaphragm, this is the crurae, right dome of diaphragm. So liver is under this. So there is something called as tidal percussion. So when the patient is lying prone, so you percuss. So there is a dullness and resonance which is increasing and vanishing with each respiratory cycle. Okay, inspiration and expiration. But when there is abscess in the subdiaphragmatic area, or there is a dense pleural effusion out here, there is empyema out here, so, or diaphragmatic palsy, so this tidal percussion will vanish. This is a very important clinical sign. And your diaphragms can be affected in multiple conditions. So various neuropathies are there. Langerhans-Guillain-Barré syndrome, multiple sclerosis, then in snake bites, botulism. So there are many conditions in which you can have paralysis of the diaphragm. So you have to be aware to diagnose myasthenia gravis, Eaton-Lambert syndrome. So the respiratory cycle consists around 12 to 14, 12 to 15 times per minute. And there is inspiration, expiration, and there is a pause in between. So when the interpleural pressure is, there's a negative pressure, it will pull the lung out. So you will suck in air. And at this point, you must remember something called as Kussmaul sign. So Kussmaul sign and Kussmaul breathing, they were discovered by the same scientist, but they are different things. Kussmaul breathing you will see in diabetic ketoacidosis. But Kussmaul sign is, you will see, we had one of our cardiologists, my teacher in Christian Medical College, Ludhiana, where I did my MBBS and MD. So he would be sitting on the central cardiac table, and he would be looking at patient, and he will say, Robert, that is inferior wall MI, that is RV infarction. And I wondered how sir could diagnose like that. So he was just looking at the necks of the patient, the collapsing of the external jugular vein. So normally what happens is when you deep inspire, the neck veins will collapse. And when there is some insult to the right ventricle, or there is fluid around the right ventricle, there is pericardial effusion, there is a myocarditis or RV infarction or bad COPD. So the neck veins will not collapse on deep inspiration. So that means the ventricle compliance is badly hampered. So because RV infarction usually will occur with the inferior wall infarction. So that is how sir used to diagnose. So this is another side note you should keep in mind. This is called Kussmaul sign. So you look at the neck veins, and you can come to know the right ventricular functioning just by looking at the neck veins. Of course, there can be tricuspid stenosis, there can be atrial myxoma, a lot of other things can be there. But overall, you can come to know, and it's an important sign. And usually when the right ventricle is functioning fine, the right atrial pressures will be okay only. So we have covered this. So now we come to lung volumes and capacities. So respiratory rate is around 14 to 15 beats per minute, times per minute. And the tidal volume is the amount of air passing into and out of the lung during each cycle. Each cycle means one respiration, one inspiration, one expiration. It is around 500 ml of tidal volume. So inhaled oxygen enters the lungs, reaches the alveoli. The layers of the cells lining the alveoli and the surrounding capillaries are each only one cell thick, and they are in very close proximity of each other. Oxygen passes quickly through the air-blood barrier into the blood in the capillaries, into the pulmonary artery, pulmonary vein. And similarly, carbon dioxide passes from the blood into the alveoli and is then exhaled. And diffusion of oxygen and carbon dioxide, it depends on the pressure gradient. So there has to be pressure gradient. If there is enough oxygen inside the blood, your lungs will take in less of oxygen. So this is maintained. So that is why in COPD and all, you should, we always say, don't give too high flow oxygen, because that will depress the central nervous system, the respiratory center, and then the drive to breathe goes. Then the patient goes into encephalopathy, CO2 narcosis, and then it becomes even more difficult for him to breathe. So the external aspiration refers to gas exchange across the respiratory membranes, and each alveolar wall is one cell. We have all discussed this. So this also we have discussed. We'll bypass. So the respiration is controlled by your medulla oblongata. Now internal respiration, I've already told you, between the tissues. So the carbon dioxide from the tissues, it goes into the extracellular space, extracellular fluid. From there it is taken up by the veins, capillaries into the veins, and it is taken to the lungs. And from the lungs again it is oxygenated and it comes back. So these are different conditions, and I think you people must be bored, and I will not go into depth of this, but I want you to see one video. It's a small video, just hold on, we'll finish fast. So this is a small video of bronchoscopy. So this is nice animated videos, just 4 or 5 minutes. Just watch so that you know what inside it looks like, and how bronchoscopy is performed. And when you're performing the bronchoscopy, if there is a suspicious mass or tissue you see, or some swelling or invagination inside the bronchus or bronchi, so you can take a transbronchial lung biopsy and you can wash the bronchial fluid. It is called bronchoalveolar lavage. You can collect it for malignant cells, for endobronchial tuberculosis. So you can do all this diagnosis. So this is how the bronchoscopy is performed. So the pulmonologist or the surgeon puts the flexible fiber optic bronchoscope inside, and it's amazing how the science has evolved, and you can go very, very, very deep into the respiratory system. So you see out here there is a growth. So this growth must have been picked up on X-ray or on the CT scan. So the pulmonologist knows where to go, how to direct the bronchoscope towards the growth, and they pass a biopsy needle and then a piece stick. This is called transbronchial lung biopsy. One of the side effects of one of the harmful effects of transbronchial lung biopsy is sometimes you develop mediastinal pneumothorax. So sometimes it can be fatal. There is another small this thing. So just watch this one also, then we'll wind up. So whenever you are doing a transbronchial lung biopsy, make sure that you monitor the patient carefully, check his vitals frequently, repeat chest X-ray at least once or twice, and keep on looking for subcutaneous crepitations over the chest wall, over the sternum, in the axilla. So when the air leaks outside the respiratory system, you will feel the creps when you palpate the skin.
In this film, we perform a tour of the normal segmental anatomy of the bronchi by means of bronchoscopy on a healthy volunteer under local anesthesia. After passage through the nose, the pharynx and the epiglottis, the glottis is reached. After inspection of the vocal cords and arytenoids, the bronchoscope is advanced into the trachea. While staying in the middle of the airway lumen, the trachea is carefully inspected. Eventually, we reach the main carina, where the left and right main bronchi originate. We then rotate the bronchoscope 90 degrees clockwise and enter the right main bronchus. At the end of the right main bronchus, we recognize several important anatomical landmarks. We identify the orifice of the right upper lobe, the right carina 1, the orifice of the middle lobe, and the orifice of the right lower lobe. We then enter the right upper lobe, which divides into the apical segmental bronchus, or RB1, the posterior segmental bronchus, or RB2, and the anterior segmental bronchus, or RB3. We then head back and extend the bronchoscope into the intermediate bronchus.
I'll be giving credit to these videos because in YouTube, if you take any video, you might get a copyright.
Here, we identify
claim.
the orifice of the middle lobe, the right carina
But these are very
2,
nice teaching
the basal
videos.
branches, and the apical segment of the lower lobe or RB6. We then enter the middle lobe bronchus, which divides into the lateral segmental bronchus, or RB4, and the medial segmental bronchus, or RB5. After going back to the intermediate bronchus, we identify and enter the apical segment of the lower lobe, or RB6. When we extend further down the lower lobe, we reach the basal branches, the anterior basal branch, or RB8, the lateral basal branch, or RB9, and the posterior basal branch, or RB10. In most cases, the medial basal branch, or RB7, can be found at the medial side of the lower lobe bronchus. In this patient, however, the RB7 is absent. This picture from a different patient shows an example of the medial basal branch, or RB7, of the lower lobe. After inspection of the basal branches, the bronchoscope is then slowly retracted up to the level of the main carina. After rotating 90 degrees counterclockwise, we enter the left main bronchus, which is significantly longer than the right main bronchus. At the end of the left main bronchus, we can identify the orifice of the lingula, the left carina 2, which separates the upper and lower lobe, and the apical segment, or LB6, of the lower lobe. Of the basal branches, the bronchoscope is then slowly retracted. We advance into the lower lobe and first inspect the LB6 that immediately divides into three subsegmental branches, LB6A, LB6B, and LB6C. We retract from LB6 and continue further into the lower lobe. Here, we can identify the anterior basal, or LB8, lateral basal, or LB9, and posterior basal, or LB10, segmental branches.
What are the chances of perforation? Very rare, but you have to be always thinking of perforation whenever you do a bronchoscopy, because you can't relax after doing a bronchoscopy. You have to look for any air in the mediastinum, around the heart, in the pleura, in the subcutaneous crypts.
When entering the left upper lobe, we recognize the upper division bronchus, the left carina 1, and the lingula. The lingular bronchus divides into the superior segmental bronchus, or LB4, and the inferior segmental bronchus, or LB5. The bronchoscope is retracted and advanced into the upper division bronchus. Here we can identify the apical posterior segmental bronchus, or LB1 plus 2, and the anterior segmental bronchus, or LB3. The LB1 plus 2 is often difficult to inspect because of its steep angle.
The lung biopsy is taken, the bronchoalveolar lavage you can take to diagnose, rule in, rule out tuberculosis, or look for malignant cells, and so on.
Once the bronchoscope is positioned well, we can see.
There are a lot of good videos on YouTube, and you can watch them. Always give credit to the author. And so we'll stop the lecture here, guys. We are over time. So if you liked, please do subscribe to the channel also, and always leave comments and share the video with your friends. If you want to watch it, you can come back and watch again. It will be here only on this link. It will be available. And it's COVID time. Stay safe and stay inside and keep studying. Any questions, please post in the comments in the offline mode, and I'll answer them. So thank you guys, and God bless. I'll be live for some time.